For the next, we'd like to invite Dr. Sunil Kota and Dr. Swayam Mangaraj. Thank you for joining us here today, sir. They'll be covering the topic of a 26-year-old girl with primary infertility, hirsutism, and a 17-hydroxyprogesterone value of 342 nanograms per deciliter.
Very good afternoon. Thanks to the organizers for those kind introductory words, and thanks to the organizing team for having me here. So I have with me my younger colleague, Dr. Swayam Mangaraj. He would be briefly taking us through the case. How do we go to that?
Can you have the slide, sir? So thank you, Chair, for that kind introduction, and I would thank the organizing team for inviting us over here. So we have been provided a case-based scenario, and predominantly many of our colleagues here are gynecologists, so they would be seeing this patient. We're just helping them out how to further progress when a patient presents with this typical clinical scenario. So the index lady is a 26-year-old lady, complaint of primary infertility and she has done an 17 OHP based on the recommendation by her treating physician, and it is 3.42 nanogram per ml. With this report, the patient comes to us or primarily referred from our gynec colleague. So what next has to be done? So I think Dr. Sunil will enumerate what does this elevation in 17 OHP suggest, and what is the diagnostic algorithm which we should follow?
See, we all understand that 17 OHP is an intermediary in the synthesis of steroids from the cholesterol, and especially in classical cases of congenital adrenal hyperplasia, the patient comes to you at neonatal stage with virilization, or a male child comes to you with salt wasting crisis. So you have definite clues as to when do you require the test to be done. But what happens in NCCAS, the non-classical CAH, good number of cases we find that the childhood and adolescence remain asymptomatic. In fact, most of them, they go on to have spontaneous pregnancy, so they are not treated. So we would be enumerating the symptoms based on which they should be tested. But then 17 OHP is the one which has to be the screening modality, and there are different methods. The most commonly available is the immunoassay, but then it is not specific, it has no antibody specificity, it has got cross reactivity, it gets false positive in patients who have additionally elevated 17-hydroxypregnenolone. Therefore, the gold standard is the liquid chromatography mass spectroscopy, but again, it has to be standardized and it is not available across. So gold standard is always liquid chromatography mass spectroscopy. And to talk about the testing pattern, 17-hydroxyprogesterone has to be done morning at around 8 AM in the fasting state. And if the patient is menstruating, it should be done in the follicular phase, not in the luteal phase. The threshold for a basal sample is 2 nanogram per ml. If it is more than 10 nanogram per ml, it is diagnostic of NCCAH. Less than 2, it rules out NCCAH. We have a borderline 17 OHP of 3.72 nanogram per ml. So these are the cases which require synacthin stimulation test, where we give 250 microgram of synacthin intravenously, and the stimulated 17 OHP after 1 hour should be more than 10 nanogram per ml. But then we have certain other conditions where the 17 hydroxyprogesterone can also get elevated, like presence of 3-beta hydroxysteroid dehydrogenase 2 deficiency. We have 11-beta hydroxylase deficiency, and also P450 oxidoreductase deficiency. So some of the guidelines, especially if you look at the Endocrine Society guideline, if you have telltale signs of involvement of other enzymatic pathologies, you should be ideally doing other hormones as well, like the 11-deoxycortisol, 11-deoxycorticosterone, DHESS, androstenedione. In this case, what happened was the baseline was 3.72, and based on the literature recommendation, we subjected the patient to synacthin stimulation, and the post-stimulation value came out to be 17.2 nanogram per ml. So now we know how to interpret these 17 OHP values. We would like to know from Dr. Mangaraj, how do we differentiate the classical variety of CAH from the NCCH, what is its prevalence, and the clinical features of NCCH in adolescents and adult females.
So I think we have now heard regarding the 17 OHP values. Remember, a 17 OHP value of less than 2 nanogram per ml virtually rules out the diagnosis of any form of CH. So because this is one investigation which is commonly done, especially when the patient is having severe degree of hirsutism or documented evidence of hyperandrogenemia, so this cutoff should be remembered. The next thing is congenital adrenal hyperplasia is broadly divided into two basic types, that is classical and non-classical. Among the classical varieties, we have two variants. One is salt wasting variant, one is simple virilizing variant. All the three are divided based on the residual enzymatic activity of this 21 alpha hydroxylase enzyme. In the salt wasting, it is less than 1%. In simple virilizing, around 5 to 10% activity is just remaining. And in the NCCH, around 50 to 70% of the enzymatic activity is still there. So based on this, they are divided. Classical CH comes to attention in the neonatal period if they have salt wasting, and in the early childhood, the severe simple virilizing presents with virilization in females. Males usually escape that and they present with premature puberty or in sometimes peripheral precocious puberty. Now the question here is, how do adolescents and adults with NCCH are presenting to us? Two specialities which commonly refer these patients to us as endocrinologists are the dermatology and gynecology, because they usually present with signs of hyperandrogenism with severe nodular acne or male pattern alopecia, or they could present with oligoanovulation, hirsutism and primary infertility. So these are the basic complaints which these individuals typically present to us. So the thing is, in which subset of patients you are likely to get a positive yield. Let's say after this talk, we will think that for every PCOS patient, which is the most common type of prevalent reproductive endocrine disorder in the society, we will send a 17 OHP. The yield will be very less. We have to be selective. It is a costly test. The reference labs have to be there for correct standardization of the procedure. So a patient who has severe degree of hirsutism, severe nodular cystic acne, who is not responding to conventional cyclical OCP or anti-androgen, perhaps in them it might be more prudent to rule out non-classical CH. Because if you look at the literature, majority of the women are not diagnosed until the young adolescent or adulthood, and in men the data is still more scarce. So they are not diagnosed even throughout their life. So here we should direct the treatment strategy based on the clinical case pickup. So these are the clinical characteristics with which the patient present to us. Another finding in a PCOS girl is clitoromegaly. So the greater degree of virilization, greater degree of hyperandrogenemia is the type which are more likely to get a diagnosis of non-classical CH, which can be established by a synacthin stimulation test. The cutoff is well enumerated by him. More than 10 nanogram per ml, if the values goes beyond that, then perhaps it is non-classical CH. Values between 2 to 10 would qualify as a heterozygote, but there is no guideline recommending treatment of these heterozygotes. They don't need treatment.
And if you were to add the prevalence, it is stated that the classical CAH is found in 1 in 10,000 to 15,000 children, and the NCCH, it is reported to be 1 in 500 to 1 in 1,000. But there are certain population where there is high chances of consanguinity in marriage. It can go up to 1 in 50 to 1 in 100. In fact, the literature says in some population like Jews, the Yugoslavians, Italians and Hispanics, even it goes to 1 in 20 also. So
you find male adolescents also at times presenting with the non-classical this thing?
Yes, ma'am.
Of course, we are talking about females right now.
We have restricted to
Yes.
females only. So usually this is
How frequently you encounter adolescent boys like with this?
exact, ma'am. The diagnosis of NCCH is always missed in males because they don't have any complaint. Only when a relative is diagnosed with NCCH by routine screening among them or for infertility. Otherwise, non-classical CH males will remain
So
undiagnosed throughout their lifetime.
Yes, there should be a strong, suspicion in such cases.
Yes, actually, Dr. Swayam has rightly stated, the subtle clinical manifestation is premature pubarchy, growth acceleration, but then what happens is there is premature epiphyseal closure, and then the child goes into short stature.
So I think now Dr. Sunil will address key issues which should be tackled when you are evaluating a case of non-classical CH adult female. So what are the basic management issues which should be addressed?
See, I think in our previous discussion only, Dr. Swayam has rightly told us the overview of what all symptoms they can present to us with. But as far as clinical issues are concerned, the predominant finding, especially in female, is the hyperandrogenism, hirsutism, acne, alopecia, clitoromegaly. And in females, there is anovulatory cycles, which is basically driven by high androgens and the 17-hydroxyprogesterone. High progesterone acts as a contraceptive also, and the high androgens can give rise to endometrial atrophy. These all are reasons attributed to subfertility and infertility. And if you talk about data, it says that around 15 to 30% patients of NCCH, they would have difficulty in conceiving. And there is a data, it says the conceiving chances of a normal couple, if it is around 65 to 70%, it goes down to 15 to 16% in a couple having NCCAH. There is also subfertility, there can be rarely primary amenorrhea, and apart from that, there is other issues like bilateral adrenal incidentalomas. In fact, yesterday I was talking on bilateral adrenal masses. I was surprised to find that the chances of having bilateral adrenal masses is around 21% if you look at radiologically. If you confirm biologically, the chance progresses to 33%. And if you were to confirm by genetic analysis, it goes up to 50% of cases. And there are some issues as far as the fertility is concerned in the males. The classical CH, there are hypogonadism, there is chance of hyperhypogonadism, there is testicular adrenal rest cell tumors, but that is not common in males having NCCAH. And in also the classical cases of CAH, there is higher chances of vaginal delivery because of the prior occurrence of higher chances of cesarean section, because of previous occurrence of vaginal reconstructive surgery, there is higher chances of cephalopelvic disproportion, but that is not there with this particular cases. And coming to bit of the genetics, it is stated that if a lady is having NCCAH, the chance of having a child having CAH is around 1.5 to 2%, but chance of having NCCAH in the subsequent child, it would be around 15%. Because it is stated that 70% of the cases of NCCH, they have compound heterozygotes, one allele representative of classical mutation and one allele representative of non-classical mutation. And fortunately, the milder variety comes to the fore, therefore the NCCH is coming to the picture. And bit of genetic counseling I would also like to address over here. It is stated that if both the alleles of the lady having NCCH is suggestive of non-classical variety, then you need not go for any genetic counseling. But if the lady is having compound heterozygote where one allele is suggestive of classical mutation and another allele is suggestive of non-classical mutation, in those cases, if the father is having at least one classic allele mutation, you have to go for prenatal testing and prenatal treatment also. With that, I would like to ask Dr. Mangaraj, how do we manage the non-classical cases of CH in adult female, non-pregnant females, and exactly what about your thoughts on females planning for pregnancy, like the regimen and treatment targets?
Now comes the most difficult and tricky part, because treating both CAH and non-CAH can be frustrating in equal parts for the physician as well as the patient. The problem here is we have now addressed the diagnosis. We have arrived that the patient perhaps suffers or most likely suffers from non-classical CH. There will be two options in adults: a female who is not desiring pregnancy. The recent Endo Society guideline endorses that the treatment should be patient-centric. Asymptomatic NCCH patients should never be treated. So a lady who is asymptomatic, just because she has been diagnosed by either genotyping or routine familial screening, they did not require treatment. Individuals who have some disorder like hirsutism or infertility, oligoanovulation, these require treatment. Now, what are the options we have? The treatment of choice for NCCH is obviously glucocorticoids. Having said that, for non-individuals who are not desirous of pregnancy but are concerned more regarding their hirsutism and oligoanovulation, perhaps the drug of choice for me or other endocrinologists would be combined contraceptive pills along with or without anti-androgens. That is the number one choice if the patient is not desiring pregnancy. Let's say an adolescent girl. 60 to 70% of individuals will be on a good control of disease with those combination therapy. Local eflornithine cream, which is ornithine decarboxylase inhibitor, that can be used to decrease the degree of hirsutism, that can be added, but they would not necessitate requiring glucocorticoids. Now comes the question, in whom you should offer glucocorticoids. Patients who are desiring pregnancy, those who had history of miscarriage, there is history of primary infertility, those are prudent candidates in which it must be offered. What drugs can you give? We have oral prednisolone, widely available, oral hydrocortisone, and dexamethasone. These are the three agents that are commonly used to treat. The drug of choice, I would say, scientifically would be oral hydrocortisone because it almost mimics the natural hormone which we have in the body. But the concern here is we have to give it 3 times a day, which is cumbersome in the long run. The only condition is in children where the growth hampering property of these glucocorticoids are significant. Thereby, we are preferring hydrocortisone to be given to children in the growing years because those have the least side effects. In other situations, once they have adult height potential has been reached, we switched over to oral prednisolone in the doses of 5 to 7.5 milligram, which are lower side what we conventionally give for classical CH. Mineralocorticoid supplementation is not required to them. And in whom would you like to give DEXA? In certain scenarios, like the patient is not responding to conventional glucocorticoids in terms of prednisolone, there is infertility, hirsutism is not controlled, hyperandrogenemia is not controlled, perhaps adding 0.25 milligram dexamethasone would be tried there. But desirous of pregnancy, because DEXA crosses placenta, is a strict no-no. So majority of the individuals would put on prednisolone and then we can subsequently follow up. Now, what are the treatment targets? You make, what are the levels, whether you measure 17-OHP, the basic hormone which led to the unraveling of NCCH? No. The monitoring should be based on total testosterone, androstenedione. This should be maintained in the in the age and sex specific cutoff ranges. That is our target, androstenedione and testosterone in the normal range. We would never like to make 70 OHP normal because thereby we will expose the patient to more of glucocorticoids. So we will adhere to androstenedione and testosterone while monitoring any patient of NCCH. We will try to keep those in the desired target ranges. And now a patient who is conceived, then what next has to be done will be dealt by Dr. Sunil.
Yes.
Yes, ma'am. If you remember, okay, so the prudent time period would be, say, at least 3 months before a next test is scheduled so that you can titrate accordingly. Not before that, it is actually 2 to 3 months at least.
And do we have any endpoint which would suggest us we require to stop it?
Okay, next thing is, do we contemplate stopping it? If someone is already on prednisolone, if the patient is not desiring pregnancy, cycles have become normal, hirsutism has improved, we may contemplate of stopping it. It is not for lifelong as a case of classical CH.
That's true. So thanks. So now that the patient has conceived, here comes a question of confusion because the guidelines tell us if there is chance of, if there is a history of infertility or if there is a history of miscarriage, you need to treat them. That has been already alluded to by Dr. Swayam. But then there are some articles which I came across and it states that NCCH ladies having pregnancy itself is a stressful situation, so they should all be treated with hydrocortisone. Again, why hydrocortisone and prednisolone? He has already told us because it is not crossing over to the child and it is inactivated by the placental 11-beta hydroxysteroid dehydrogenase. Again, the question comes, how do we monitor? First of all, he has already told us that the 17-OHP is normally elevated in pregnancy, so it is not an ideal marker to be followed. We have other pointers like testosterone, And the Endo Society also tells us you please rely on the symptoms of adrenal insufficiency like fatigability and postural drop of blood pressure. And then what about the dosage during pregnancy? How do we upscale in the later trimester? It is stated that for ladies having classical CAH, at the time of conceiving itself, you increase the dose to 20 to 25 milligrams per day, and every 6 to 8 weeks they generally require a dose enhancement based on the literature available. But for NCCH, they say we do not have sufficient evidence to tell you what exact dose has to be started, but it also tells us around 20 to 24 weeks it would always require a 20 to 25% enhancement in the dose. That's what is the trend. And of course, because there is a requirement of steroids, we should be more aggressive in monitoring the blood sugars and blood pressure. That is very important. And what about the stress dose in pregnancy? There again, there is no clear-cut guidelines as to what has to be given, but then it states that if the stimulated cortisol value is less than 14 to 18, that means 1 hour after synacthin, if the cortisol is less than 14 to 18 microgram per deciliter, you can go for a stress dose. The dosage is not yet specified, and there is no increase in chances of cesarean section, as I have already stated, because in NCCH we do not require vaginal reconstructive surgery, or there is no higher chances of cephalopelvic disproportion. And lastly, I would be adding few points about the prenatal testing and treatment. See, the Endo Society guideline, which Dr. Swayam was also alluding to, it tells us till it is an experimental treatment. They say if you want to go for it, then you have to get it cleared from the institutional review board, and you have to give it to only prospective female birth, the lady who is giving birth to only a female. So it asks us to go for genetic screening of demonstration of Y chromosome in the maternal blood. But in places like India, where the sex determination is an issue, the Endo Society says we would not recommend it. Rather, you have to go for the CVS, which is ideally done between 10 to 12 weeks. But again, here also there is an issue, because the virilization starts in 6 to 7 weeks. So if you are to prevent the genital virilization, you are supposed to give it at 7 weeks. But by CVS, you will be detecting it at 10 to 12 weeks. So that again is an issue. And
one more thing I would like to add here. You can see whom are we targeting to treat. We are targeting that female child who is going to suffer from CH. So having that is 1:8.
1:8.
That means out of 8, only one child would have a female who is having the disease. Rest we are treating unnecessarily. So for that very reason, it is still considered experimental.
In fact, it is stated that for females you have some advantage, that there would be less social stigma, there would be less the emotional issues, there would be less requirement of vaginal reconstructive surgery, but for males it is of no use. But then the patient should always be counseled that there still would be a requirement of lifelong hormonal replacement, there would be still requirement of monitoring, and also she would be requiring stress doses in between if required. And then what is the dose? It is stated that the dexamethasone is given at a dose of 20 microgram per kg body weight, maximum of 1.5 milligrams per day. And there are some issues, maternal issues like weight gain, edema, stria, there can be cushingoid habitus, and also fetal issues. It is stated that there is teratogenicity at this dose. Fetus can have cleft lip, cleft palate, and also they would be having developmental issues as far as the thyroid, follicular and C cells are concerned, and there would be also less number of oogonia. There is issues with regards to brain development. The child also becomes, the child who is born has less birth weight, less birth length, so that the long-term onset of chronic metabolic complication is also higher. So we have under 2 minutes to go. Swayam would take us through additional issues.
So I think we have now diagnosed the case, managed the basic issues including primary infertility, hirsutism and oligoanovulation. Having said that, once you have managed this, there are certain long-term outcomes which need to be addressed, because glucocorticoids are potent drugs. They are bound to affect your metabolic health in multiple ways. So certain key issues which should not escape our knowledge with regards to management of non-classical CH especially would be the stress, because psychosocial stress and the disease per se takes a toll not only on the individual but as for the family also. So there should be a low threshold for seeking a psychiatric evaluation and help if needed. Don't step backwards. Give your patient, if there is slighted hint that patient is depressed, then formally take a psychiatric consultation, because a lot of studies from the West have suggested that 30 to 50% of individuals have some form of depressive disorder while they are managed with NCCH. So that is the key point. With regards to metabolic health, obesity and cardiovascular disease are almost same or slightly excess in this population. So population specific threshold for screening should be also given to them, and appropriate management for them should be taken into account. One key thing is, if your androgen levels are high, we expect the bone health to be good. That is what the common notion is. Some observational studies have supported this notion, but whereas others have suggested that the bone health is not improved in these individuals where their treatment de novo. Once you initiate them on glucocorticoids, it is prudent that a repeated annual bone mass or DEXA assessment at least 3 to 5 years should be done to look at the deteriorating bone health, because long-term fractures are quite common in individuals who are given long-term steroids, especially in conditions like adrenal insufficiency, even in the physiological replacement doses. I am not talking about excess doses. In normal physiological doses also, this has to be taken care of. So I think we have talked, almost covered basic areas, including management issues. So I think we can have some discussion if you have any.
I'd like to add something here, Dr. Sunil and Dr. Swayam. You said that CAH is more common in female fetuses, or that is what we are looking at avoiding. Yeah, not more common, sorry, I correct that. And you said that we can't do a pre-implantation genetic testing for females. So we can't do it to discriminate males and females, but we can do it if we've done a genetic testing or genotyping on the parents. We are doing pre-implantation genetics to avoid CAH in the baby. That can be done through IVF.
That is also what is endorsed by guidelines. Genotyping is a must in centers where you have facility, so that you can prognosticate the parents what is the chances of having an affected CH or NCCH baby. That has to be done.
In fact, for diseases like CAH, it is something which is recommended. We even get patients now who are diabetics, some with IDDM, some with NIDDM, who want their children not to be diabetics. So that is again a gray zone. For diabetes, we haven't done PGT yet.
But I think that is too far ahead. But for CH, it is definitely endorsement.
There is one silver lining in the dark clouds, because some of the states have launched NEEV, that is neonatal early evaluation vision. One component of that is screening for congenital adrenal hyperplasia. And I think it is a very good step in preventing these problems in this developing newborns and children. We are soon going to be adolescents who will suffer later on if not diagnosed in time. So that is a very important point. And another thing is, thank you for highlighting the mental health aspects, because so many cases we have already discussed regarding PCOS also. In these mental health issues are very, very important, which have to be separately taken care of by an expert. Thank you for highlighting that.
And in practice, we are getting more of the compound type and mainly associated with PCOS. We are not getting more of non-classical. We are getting the compound type. The values are usually between 2 to 10.
Correct, ma'am. If there's compound heterozygotes, you treat by a combination of ocipils
Yes.
and anti-androgens. That will
And
suffice.
I must make my obstetrician friends aware of this salt losing variety, because when we were taught about this, because they may be cause of SIDS, that is sudden infantile death syndrome. The mother will say the baby was all right a day or 2 days before, and now suddenly the baby is no more. So one should be very, very cautious, and we should have a strong suspicion if such an history is available of sudden infantile death syndrome in a couple.
In a place like Delhi, do we not have mandatory neonatal screening for all
in
these
Delhi
disorders?
government hospitals, we are doing NEEV.
That's
We
nice.
are doing screening, neonatal screening.
Even in private.
Only,
and
madam, I will just add one thing. NBS or newborn screening is a very important tool for identifying early those patients who will have CH, but that threshold is very less for non-classical CH. Majority of individuals who are going to develop non-classical CH will be missed in that newborn screening. Only who have simple visualizing and salt wasting, those would be picked up. But that is what we want to prevent. So I think that is the purpose of
Another
NBS.
is congenital hypothyroidism. There are 3-4 components like premature retinopathy and all these things. They are very, very important. So all the government and I think private setups are also now going for that.
Nalini, the subsequent speaker is very anxious, so I think we have to
There are
invite.
two
Thank you.
board of our talk and they quickly want to come
Thank
on.
you all for that patient
Okay,
listening.
thank you all.
Thank you.
sir.